Thank you. It's wonderful to be here. I live in Darien, so I didn't have to travel far. Can you hear me?
Yes.
Great. Just so you know, on Thursday we had no heat, so you chose the right time to come. Let me tell you just briefly about our business, because we're unusual, and then you'll understand how we have the knowledge we have to talk about Medicare this morning. We are an insurance consulting and advocacy firm, so we're not selling any products. On one side of the business, we're providing consulting advice, largely to people who are losing their group coverage for the first time or transitioning onto Medicare. You know, in the United States, we all aspire to have wonderful group coverage during most of our lives, but there are many events that kick us off of that. Our children turning 26, moving from state to state can have an impact, retirement, divorce, death of a spouse, all of those things. The other side of the business is more advocacy, so that we have long-term relationships with clients and we can really intervene to solve all kinds of problems for them. So between that group of clients and the new clients who come to us with some kind of problem, we learn an awful lot, unfortunately, by trial and error. Things that aren't in the Medicare and You book. I can see that many of you are likely already on Medicare, so you should be getting this. If you don't, you can always get it online and download it. There's a new version every year. So, and I should say, the last 70 pages of my book, which is easy to find, it's #1 on Amazon under health insurance, is all case studies, and the last 70 pages are on the transition to Medicare and Medicare. So you don't even have to buy it, you can get it here at the library. I selected topics today that are not the basics about Medicare. You know, the basics about Medicare are Part A is largely covering inpatient services, hospital, skilled nursing, some home care. Part B, medical services. Part C is Advantage plans. We'll talk about those to some extent. Part D, the outpatient prescription drug program. I'm hoping that most people understand those basics. And I've chosen to talk about topics that I think are less well understood, that more people should understand. The mistake I made Thursday night, the presentation was well received, but I think I allowed too many questions as we were going through it. And then I felt like I was racing the clock. So I'm going to try to control that better. I just ask for your patience, save most of your questions, and I'll try to be as clear as possible. But, you know, Medicare's approaching 50 years, it's almost 50 years old. You know, it passed in 1965, and it started in 1966. So just because of its age and all the various agencies that regulate it and all the changes in legislation that occur, it's more complicated. And it will become more complicated, particularly for those people going on to it for the first time. So I thought we would talk about enrollment periods, which I realize isn't relevant to everyone, but we're going to cover that. Working beyond age 65 and income indexing and how it actually works. Medicare Advantage plan supplements and retiree medical. Coverage outside the U.S. Doctors opting out of Medicare altogether and concierge medicine. And then I've got a sort of a potpourri of Part A issues I'd like everybody to understand. Because in some ways now the Affordable Care Act, for those under age 65 or who are over and have large group coverage, is richer in terms of hospitalization benefits than Medicare. And everybody on Medicare should understand that well, and how you get that catastrophic hospitalization. Any other topics? Do we need to somebody the other night wanted to talk about the Affordable Care Act. you know what? Oh, I should say, I'm on the board of Access Health CT, Connecticut's insurance exchange or marketplace. I'm supposed to say that every time I speak somewhere, that I'm not speaking as a board member of Access Health CT. I'm speaking on behalf of Healthcare Navigation. But the Affordable Care Act provisions that are going into effect in 2014 don't have much of an impact on Medicare. The donut hole is supposed to be closed in 2020. Let's not talk about 2020 today. We have enough going on in 2013. Anything else we need to add to the list?
Penalties or?
Penalties, yeah, that's part of enrollment periods. Lifetime premium penalties. Yes?
Supplemental insurance to Medicare?
Governmental?
Supplemental.
Oh, supplemental. Yes, that's on the list. That's on the list. Good. Okay, then let's dive in. Enrollment periods. If you're getting Social Security when you turn 65, the government sends you your card enrolling you in A and B. If you don't need B because you or a spouse have active large group coverage, you can opt out of B. Large group is 20 or more, and it's got to be active. So those people have it easier than everybody else. They just get sent their card. If they don't need B, they can opt out of it. Otherwise, you're enrolled in A and B, and you have to figure out, do I need D? What kind of supplement am I going to get? Should I consider an Advantage plan? You always, and we'll get to what that is, but you always need to have Medicare Parts A and B to even consider an Advantage plan, which is an alternative to original Medicare. Yes?
Could I just make a point about B that maybe you could clarify? When you say active in group insurance, it means that you have to go to work every day. Not that even if you have full coverage, if you don't go to work every day, that doesn't count. You still have to take Medicare Part B is what I was told.
Yeah, let me come back to that. Because if we get through all the enrollment periods, it might become more clear. So the reason the government sends you your card when you're about to turn 65 is because you're in your initial enrollment period, which is the 7 months around your 65th birthday, 3 months before the month of your birthday, 3 months after. If you need your Medicare when you turn 65, you really need to be enrolling a couple of months ahead of the month of your birthday. Because if you enroll during the month of your birthday or after the month of your birthday, your Part B effective date is delayed by a month. You don't have penalties, but it's delayed by a month. So you want to be on this a couple of months before your birthday. If you're applying for Medicare on your own work record, because most people are entitled to premium-free Part A because they've worked or they've been married to someone who worked and paid in long enough, and the marriage lasted long enough. So the system protects the at-home spouse to some extent, but you really do need to enroll. Actually, if it's your work record, you can enroll online now. The online tools have gotten better and better. So this is for people who aren't taking Social Security. Many people are opting to defer taking Social Security, in which case you're responsible for your enrollment in Medicare. Again, if it's your work record, you can go online to ssa.gov. Social Security manages Medicare enrollment. They share a database, and you can hit Medicare, apply to Medicare. You have to check that you're not blind as you go through the process, which is interesting. But the online tools have gotten better and better, so that's a great thing. The people who do have that active group coverage, active, not retiree medical. If you have retiree medical, the retiree medical expects you to be on Medicare A and Medicare B. But if you have active group coverage through a group of 20 or more employees, through your work or a spouse's work, you have a special enrollment period. And whether or not you want to enroll in B at 65 is optional. It's your decision, because you're entitled to a special enrollment period. And this is where so many people today get tripped up, because when Part B was very, very cheap, I mean, I'm getting up there, you can tell. I've been around a long time doing this, and I remember when Part B was so cheap that even those people who were working beyond age 65 said, just, you know, let's just sign up for everything. Let's get A and B, and then I don't have to worry about it again. I'm already in when I decide to retire. But more and more people are working beyond age 65 today, and Part B is income indexed since 2007, so they don't want to pay for it until they need it. But it's important to know that the entire time you have that active group coverage, you're in a special enrollment period. You can enroll in Part B anytime, any month you want, should you change your mind. Let's say your group plan isn't as good as it used to be, or you're dealing with serious illness and you want as much coverage as you can have. But the kicker is, when you retire, you've got a plan to get on B and do what else you have to do, because the clock that ends the special enrollment period starts clicking. I mean, ticking. It's 8 months long, and so there are many people who have problems with this because the employer is still offering them COBRA. COBRA's a temporary extension of group coverage. If you take COBRA, and I mean, some people do, even though it's expensive. If you take COBRA for 18 months, you've missed your special enrollment period for B. Some people have severance arrangements, which includes extending their health care coverage. They miss enrolling in their Part B. And others have sold businesses. There are many scenarios where someone can not understand this well. So, the last way you get onto Medicare is your general enrollment period. No one wants to get on Medicare during the general enrollment period. If you get on Medicare during the general enrollment period, you've goofed, because you only want to get on Medicare during your initial enrollment period or your special enrollment period. The general enrollment period is the first quarter of every year for an effective date the following July 1st. So it's designed to be punitive, meaning you may have a gap in coverage, and if you're older than 66, you're going to pay lifetime premium penalties for every year back to your 65th birthday. Okay? And the reason it's designed to be so punitive is the government wants your Part B premium as soon as they're entitled to it, pretty much. Even though if you stay on active group coverage, in a sense, you're saving the government money, right? You're saving Medicare money. But basically, it's set up to be this punishing because the government doesn't want people looking at the cost of Part B and saying, you know what? I'm healthy. I don't need that right now. I'm going to wait until I'm older and sick. They want everybody paying in. So, the questions we got the other night, well, what if you have lifetime coverage promised to you by a former employer? That's a great thing if you do, but it's very few people who can count on the fact that that might not change. I mean, we've had CEOs of steel companies and people who all thought they were going to have lifetime benefits, and that didn't pan out. Sole proprietors do not get a special enrollment period. So if you had coverage as a self-employed person, that doesn't factor into this. Let me give you a real life example, because a couple of years ago we dealt with someone who was 79. She had always worked. She was incredible. And now she wanted to retire because her husband was ill. Obviously, he had been the one taking care of things, because when I said, did you get on Part A when you turned 65? She said, how would I know that? And this was a very sophisticated, well-educated woman. And I said, well, you should have a card that says hospitalization, Part A. But anyway, long story, just a little bit longer, she did have Part A, and she had to get on Part B during her special enrollment period. She was a professor at NYU at the time, and she had also been CEO of a smaller entity in Manhattan years before. And the special enrollment period is different because you can't go online for that. You've got to call Social Security. They've got to send out forms, one that you fill out, and the other that every employer you've had the group coverage through since you were 65 has to fill out. So it's not an honor system. You don't go online. Someone has to sign, and Social Security wants an original signature. Copies of those forms are in the back of my book, so you can just see what they look like. But this woman, we had to get people to sign the form. I mean, no one was around who was there in 1997. There had been, even though she was CEO, like, you know, the reaction from the company was, who is this? And we don't have any records from 1997. Are you kidding? Nobody wants to sign this form for the government. So it's probably not a bad idea. We still haven't run into the situation where the company's gone out of business. And there's nobody to sign, because they want a company official to sign this form. So it's not a bad idea if you get a letter of creditable coverage. Does everybody know what that is? When your coverage ends, you get a letter that says your coverage went from this to the... Not a bad idea to just save those. Enrollment periods, we've focused on A and B. There are different enrollment periods for Medicare Advantage plans, which we're going to talk about in a minute. Different still for Part D plans, which, you know, you can go on COBRA for 18 months and still get your Part D after that with no penalty. So this is a document. It's 6 pages long, and it explains Medicare enrollment periods. We didn't bring enough for everybody. If you want it, take it. If there's not enough, just email us. We have cards. I have several staff here, and we'll get it to you. And so why don't we move on and talk about how income indexing works.
The quick question was on the 8 months. Is that surrounding the date you're ending? Is it before the date or after?
No, it's after.
Okay.
It's after. Oh, you know what? Actually, I was looking at this last night, and this document says, use this period. It's referring to, you have group covered, you are covered by COBRA insurance that extended. You know what? I just wanted to make a point that COBRA is usually not a good idea if you're Medicare eligible. We can talk about that if you want, but with rare exceptions, it's usually not a good idea. The employer is still obligated to give you the COBRA notice, but it's usually you should just plan your transition onto Medicare and not go through 2 transitions. Right? Okay.
Well, if you're already on COBRA and it's getting to the end of the year, and your birthday falls towards the end of the year, sometimes it makes sense to stay on COBRA just because if you've met deductibles and things like that.
Yes, but many insurance contracts are written that if you are eligible for Medicare, they expect you to be on Medicare. So you have to be very careful. And as an employee, you don't see those insurance contracts. You just get your little skeletal summary of benefits. You know what? I think we just really need to move on to income indexing. So I just ask that you save your questions. Sorry. And you know what? I'm happy to stay. My staff will stay if there are questions afterward when they, give us the hook. Income indexing. For the first 40 years of Medicare, there was no income indexing. Everybody paid the same. That was probably very foolish because then there was such a need for more money. So Part B started being income indexed in 2007. And if you, where are my forms? If you are an individual and your income tax return shows income of $85,000 or a couple filing jointly shows $170,000, that's the threshold where you start paying income indexed B, and then in 2011 D. And the way that works, let's say, let's pretend I'm going on Medicare November 1. I'm not old enough quite yet, but let's just pretend I'm going on Medicare November 1st. Then the government is going to use the tax returns that were filed in 2011 to determine my income indexed premium. And there's 5 tiers. So if as a couple you make $428,000 or more, you all pay the same. That's where it maxes out, your income indexing. An individual, $214,000. So there's these 5 tiers where you pay more. If you have a life-changing event, for example, you retire, then your 2014 income might be substantially less than the 2012 the IRS and Social Security are going to use to calculate your income index premiums, right? Because your working years were higher income years. There's a form that, to our great dismay, most people don't seem to be told about. Medicare income related monthly adjustment amount, life-changing event. So if you have a life-changing event due to marriage, divorce, death of a spouse, work stoppage, work reduction, loss of income producing property, loss of pension income, or an employer settlement payment, things that might have inflated your income, but your current or projected income for the next 2 years is going to be lower, then you can fill out this form or work with your accountant to fill out the form, make an appointment to go to Social Security and say, Social Security, I request that you base my income indexed premiums on current projected income rather than those higher income years from a couple of years ago. And some people need to do this for 2 years, and otherwise they may be paying inflated income indexed premiums.
Is that how, what's the form called?
Pardon me?
What is the form called?
What's the number of the form?
Or the number?
The form is called SSA-44. And it's also, I think, in the back of my book, a copy of it. But it's called the Medicare Income Related Monthly Adjustment Amount, Life-Changing Event. Okay?
Or if there's any difference between earned income and total income, would you highlight that?
You know what, the way, again, before 2007, the IRS was never involved in any of this, but it's you know, it is some tax-exempt income that gets factored into this as well. Yeah. All right, are we ready to move on to supplements and? All right, one quick question, sorry, then I'm gonna have to go back to this woman too. Quick.
But isn't that what okay time to mention that if you make under $80,000 a year, that they, at Darien Human Services at Town Hall, you can apply for a Medicare savings program?
What is the income threshold?
It's, I have the sheet right there that gives you roughly 80,000. It's not asset based, but it's based on your income. So if you do make roughly under 80,000 a year, you're eligible for a low income subsidy.
Under 80,000?
Roughly 80, I forget the exact number, yeah.
Well, there's got to be some people paying the base premium.
104.90.
104.90, yes, I know. I thought it was a lower income threshold than that, but that's not my field. So, Allie, that's, you know, in Darien, the Department of Human Services, Allie into Adams and others, and in every area you live in the U.S., there's somebody who can help you with that. But you should know what you qualify for. Everybody should.
And it's confidential, no one has to know.
Yes. And we've got material here.
You have to go to the Social Security, or can your accountant take care of that SSA 44 form? You said go to the Social Security office.
Yes, you have to take this to your Social Security
You
office.
can't do it through an accountant. You have to.
No, you could work with your accountant, but you need to go to Social Security. Okay. Let's talk about Medicare Advantage plans, supplements, and retiree medical. Medicare supplements came first, and the reason they exist is because Medicare was structured like the major medical plans of the 60s. There's deductibles and there's coinsurance. And so people buy supplements, which are private insurance products, to supplement after Medicare pays. And there's very good information on the Connecticut Insurance Department website. So if you go to the Insurance Department website, you can go to consumer and then health insurance and then Medicare, and you can find this information that shows all the supplements, all the companies that sell them, and what the premiums are. And this is usually pretty accurate. You know, it can be off by a few dollars, but it's usually very accurate. And the hazard with these things is they are regulated by both the federal government and the states are very different. So if you, is everybody here from Connecticut? Good, because we had New Yorkers the other night. And we can just talk about Connecticut. But if you move, you know, you've got to realize that it's likely that you should change your supplement. But in Connecticut, there is a wide range of premiums for the exact same product. What the federal government does is regulate the benefits. So what's in a Plan F is the same no matter who sells it to you. What's in a Plan A is the same no matter who sells it to you. But in Connecticut, you have the pleasure of paying, say for a Plan A, $122 a month or $558 for the exact same coverage. And why do people pay more? Because there are people selling those products and people don't know better. So what you need to know about moving is that the states are still very different. And it's unclear how the Affordable Care Act might change this, because with non-Medicare coverage, medical underwriting is going away. Medical underwriting is having to fill out a health questionnaire when you apply for coverage. As long as you apply for it during an enrollment period, it's guaranteed that you're entitled to it. That's true with Medicare supplements as long as you apply during an enrollment period. But what if you don't? In some states, they will require that you fill out a health questionnaire, and they still have the right to deny you. So you need to be careful about that. And I think, in our experience, AARP, United Healthcare, and I'm not plugging anybody, but I think they've always honored people moving from state to state. But in many states, and Florida's one of them, these products are medically underwritten, meaning the insurer does not have to give it to you if they don't like what's on that health questionnaire. And we don't know what the future of that is. But the states are very different. New York is different still. Everybody can get one anytime, but there's a 6-month waiting period. And Connecticut is different still, because Connecticut leaves it to the insurance company to determine a waiting period. So you have plans that offer 0 to 6 months. So we got a call last week. I didn't talk to the gentleman. My daughter, who runs our Chicago office, did. And this man had $361,000 in hospital bills from his wife exhausting Medicare Part A, but surviving that long to run up those bills. Had she had a supplement, which has an extra 365 days of hospitalization in it, she would have had more protection. So that's a pretty sad thing. If you have retiree medical, you need to try to find out if it has catastrophic hospitalization in it. But the supplements, it used to be that J was the most comprehensive. You can't buy J anymore. You might have J because it was grandfathered, but H, I, and J used to have drug coverage in them before Medicare Part D came along. When Medicare Part D came along in 2006, which covers outpatient drugs, the supplements had to remove the drug coverage for people being sold those from the benefits. So a J became almost identical to an F. So right now, even though you have A through N minus E, H, I, and J, the richest is F. So you want to gauge things by the cost of F, which covers 100% of the deductible and coinsurance. And there's a high deductible F, where you pay around $2,100 out of pocket a year, and then that acts like a full F if you reach that. And as you would imagine, that's much cheaper. So you have to decide. There's another page here, and again, this is available on the Connecticut Insurance Department website. There's a lot of good information that shows you the differences in these plans. We tend to recommend either an F or a high deductible F, because we've had many people have an A and have buyer's remorse because of the absence of skilled nursing facility coinsurance coverage in there. And foreign travel emergency we're going to talk about, because supplements generally supplement. They pay in conjunction with Medicare and fill in the gaps. That's why these are also called Medigap plans. But they have a couple of extra benefits, some of them. One is a $50,000 lifetime travel emergency benefit, and the other is that extra 365 days of hospitalization coverage. Okay? But remember, these are private products. They're not government products. They're just regulated by both the feds and the states. In general, I mean, this is a gross generalization, but it's in general, AARP United, USAA, and the Blue Cross Blue Shield plan are those, and Globe, but no one ever is comfortable with Globe as a rule because it's not a national, well-known carrier, tend to try to have the most competitive premiums. And that can vary. Yeah, in our state, Anthem, that's Blue Cross Blue Shield, USAA, and AARP tend to work the hardest to have competitive premiums. That varies by, you see Aetna and Humana in other parts of the country, but locally, that's pretty much the case. Let's talk about Advantage plans for a minute. That's Medicare Part C. And those are an alternative to original Medicare. There's a lot of confusion about Advantage plans because we've had people who signed up for them thinking that, well, that's my secondary coverage. That's not really correct. If you've got a supplement, your supplement is your secondary coverage. If you have retiree medical, the retiree medical is your secondary coverage, meaning that's the coverage that's going to pay after Medicare pays. But if you have a Medicare Advantage plan, you've elected to get out of original Medicare, and that is your coverage through a private company. Sort of similar to Part D. Part D is a government benefit, but only administered by private companies. Advantage plans basically are private insurance companies who receive from the government what the government thinks they're going to spend on the average Medicare beneficiary. Okay? And when you elect them, you are usually locked in for a year. So right now you could sign up for an Advantage plan, and it would be effective from beginning January 1. And the Affordable Care Act does have a provision that if you have a 5-star plan in your area and you have buyer's remorse about the plan you signed up for, then you can switch off cycle to the 5-star plan. But you know, the rating system is fairly new. So let's just talk about whether or not those are good alternatives locally. They can be. They can be. The history of Advantage plans is trying to offer you something that's less costly than staying in original Medicare and having a supplement. If you go back in time, you might remember Oxford, years ago, was the leader in this area, offering drug coverage even when there was no Medicare drug coverage. There was no Part D. And there are more products than there used to be. These used to be all managed care type products, which means a network. So worst case, I worked for Kaiser Permanente and grew up with Kaiser Permanente, which is a nonprofit health insurance company that's still very prominent out west. And they had Advantage plans, so I would never be one to criticize Advantage plans. But they don't have as great a track record in this part of the country. And so you just have to understand when you choose one what you're getting into. There's a network, so that's not just physicians, but it includes physicians and hospitals. So we had someone come to us in crisis once. He had joined an Advantage plan to save money. Then he was diagnosed with cancer, and he wanted to go to Sloan Kettering. Sloan Kettering was not in his network. And he didn't have a plan that had an out-of-network benefit. That meant to go to Sloan Kettering, he would have to pay cash. Whereas if he were in original Medicare, that would have been covered. So you just need to understand most Advantage plans still have networks, although some now are PPOs. They can have high out-of-pocket maximum costs, so you have to look at the detail, and they can have more rules, more prior authorization rules, just more of the hassle factor, like non-Medicare coverage in Part D. All right? Yes, Vicki?
So when you sign up for a Medicare Advantage, you can only enroll in that October, November through December part? Or can you enroll whenever you want to?
Oh no, we're in the enrollment period now for January 1, just like Part D. And then Oh, there's so many little provisions here. Where is it? Initial enrollment for Part C and D. So we're in that now. And there's also an opportunity, where is it? In January and part of February, if you're in an Advantage plan, to return to original Medicare. And there's all kinds of things, as we discussed the other night. Going to prison and getting out can create a special enrollment period for you, but we don't advise that.
Are there any Advantage plans that cover prescription drugs?
Yes, but you have to be very careful because some do and some don't. And you have to be very careful because some have that foreign travel emergency and some don't. So like anything else, you need to know what you're buying. And in the back of your Medicare and You book, these are listed. And you can go online. You know, Medicare.gov is a very good resource. Lots of good information. Even during the government shutdown, it still looked pretty reliable, even though we were nervous about that. Retiree, yes?
Is it true that you cannot access the Medicare website through an Apple computer still?
Through a...
Through Apple? Because I know for a long time when I was trying to manage my brother's benefits, I couldn't fill in the forms that you could do online. And I finally called and they said, this is about 2 years ago, that you can't use, you have to use a Windows-based computer for the government.
Gosh.
But it's fine, I use it all the time.
You do?
Oh, okay. I thought any browser. You just go to, okay. So there's SSA.gov to enroll, Medicare.gov. MyMedicare.gov, you should create an account. If you're on Medicare, you should create an account. You want to see that what the government has on file matches what you think you have. And so you go to mymedicare.gov, hit create an account. There's only 4 elements of information they want: your name, your Medicare number, your date of birth, and your zip code. And then you can get through to create a username and password, and then go back and use that username and password. And a good thing to always check is that the address that they think is on file is the address you believe is your actual permanent residence. Because your Part D is supposed to match. Let's just talk about retiree medical for a minute. It's a dwindling benefit, and it was, for those who still have it, you just have to periodically evaluate how good is this. Because it can change over time, and we are still seeing with our clients the entire gamut of coverage that is excellent and truly an outstanding retiree benefit, and coverage that you just you shake your head and say, why don't they just do their retirees a favor and say we're getting out of this business? And you have a lot of activity with private exchanges. We dealt with that with Deutsche Bank a few years ago, where instead of offering retiree medical, they were giving retirees $2,000 a year and saying, we've set up arrangements with all these options for you, you know, go forth, good luck, and pretty much you're on your own. And that changes the company's liability substantially to just that $2,000 a year. So all of these are trends, and retiree medical, if you have good retiree medical at a reasonable cost, especially the drug coverage, can be fantastic compared to Part D. However, you know, if you end up with a retiree medical that has a high deductible on the medical side, then, you know, you can end up with, you know, paying an awful lot out of pocket before that coverage kicks in for you after Medicare pays. So again, every so often you just have to evaluate it. If you lose your retiree medical, that creates a special enrollment period too. Okay. Let's just briefly touch on coverage outside the U.S. because every year we get calls from from people who have believed that Medicare would cover them while they're outside the US. Medicare only covers you under the rarest of circumstances outside the continent and Alaska and Hawaii. It's when you're traveling near the Mexican or Canadian border and you have sudden illness and their hospital is closer. That is not a very frequent occurrence. And the same is true if you're traveling, and the verbiage is something like from the continental US through Canada directly to Alaska. But what you need to know is many retiree plans have some foreign travel emergency in it. Some very high-end credit cards have it. But if you don't have it, our recommendation is, and if you have a supplement and have that $50,000 in there, save it. But if you're going outside the US, get some kind of travel coverage protection. Ideally, both medical coverage and evacuation, depending on where you're going. And people have told me, you know, all those countries in Europe, they don't bill you, they just take care of you and you never get a bill. That's really not true anymore. I mean, we had a call last year from a gentleman who competed in a senior rugby tournament in Scotland. And part of me was saying, what were you thinking? But, you know, he ended up with his $72,000 bill. And, you know, they saved his life, but these countries have all gotten better at generating bills. Another poor woman, no, I really felt sorry for her. She was originally Canadian, married an American, back visiting family, was hospitalized in Canada, but so close to the Detroit, the Detroit area. And if she just could have been stabilized, I mean, her Advantage plan would have covered urgent and emergent care, but it ended up, she paid them, and she believed that her Advantage plan had that foreign travel emergency, and it didn't. Again, I'm not selling anything, but we've had good experiences with MedX Global in Maryland. I visited their headquarters, I know their people, they've paid claims, and so I have a level of confidence in them. And you can buy their coverage online. You know, the reverse is true. I mean, we have clients outside the US, and we have clients with relatives outside the US. So, you know, last summer we had the client who wanted, I mean, the daughter was getting married and they wanted to bring grandma from England, grandma's 92, to the New Hampshire wedding, and the British Health Service is not going to cover grandma at the New Hampshire wedding. So this is going to be much more of a problem in the future as people don't stay in their home countries. And we've had a number of Canadians who clearly have been advised by their financial advisors, oh, get out of this country, taxes are too high, and then they didn't factor in the healthcare piece. So everybody's got to think about their coverage when they're outside the US. Okay, let's talk about doctors opting out of Medicare. This is a problem. It's a very scary, scary trend. Today, it's still a small number of doctors. The CMS reported the number for the first time for 2012. So in 2012, according to CMS, the Center for Medicare and Medicaid Services, 9,539 doctors had opted out of Medicare. That means they're not taking Medicare at all. And out of approximately 685,000 doctors in the US, you know, that's 1.4%. So it's small, but it's a scary trend. You should never be surprised if you go to a doctor who's opted out of Medicare, because they're supposed to give you a private contract. And the private contract is just 2 or 3 pages that states again and again, you understand that I don't participate with Medicare. You understand I can't submit claims. You understand you can't submit claims. You understand your supplement won't pay. You're paying me cash. And you both sign it. There are some surgeons at the Hospital for Special Surgery that have opted out of Medicare entirely. We have had clients who had surgical procedures there and decided to just pay cash. Everything else was covered by Medicare. So that's the one thing you have to know. The admissions covered, everything, as long as it's a medically necessary admission, it's covered. But historically, this has been a problem limited to primary care practices for the most part, the medical specialties, particularly the medical specialties that have relied on visit income as their primary source of revenue, and they don't have procedures that pay them more. But lately, you see more gynecologists opting out, and we just heard from our first client who has an oncologist who opted out. And that's a disturbing trend. But at the same time, you have to remember 98% of American doctors currently are participating in the Medicare program, but they do have a right to say, I'm not taking new Medicare, I'm maintaining a waiting list. But in the major medical centers, but for the Hospital for Special Surgery, Mayo, Sloan Kettering, Dana-Farber, MD Anderson, we still haven't seen any doctors opting out of Medicare because they act as an entire group. Concierge physicians, those kind of arrangements are all over the lot. Some of those doctors who charge a fee to you for being covered by them are participating with Medicare, and they're charging a fee for non-Medicare covered services. Access primarily, but there could be other bells and whistles. But some have opted out of Medicare entirely. And this is based totally on geography. So you can move to a part of the country. Actually, outside of Fairfield County, we've never run into a physician outside of Fairfield County who's opted out in Connecticut. And people will tell you, doctors can't opt out of Medicare. Au contraire, they can't. But you can also be talking to a group in Manhattan, and you can tell that the audience thinks there are no doctors left who take insurance or participate in Medicare. And I said to one group once, has anybody here ever heard of Westchester County? And it's really just up the road. And Westchester County is different still because it has large multi-specialty group practices, which we don't have a lot of in Fairfield County to speak of. And because they have been able to have a broader revenue base, they're still participating in everything and working to to be in network with plans. So it does depend on your geography. And it's just something, again, you need to factor into the equation if you're planning to move. Okay, we're making good progress. Yes?
You said supplements won't cover physicians?
Supplements will not cover physicians who've opted out of Medicare.
Okay.
But if you have retiree medical,
No.
it might, but no,
This was 2 years ago. It's changed, where I had a doctor that did not accept Medicare, and I then had the bill through the supplement, which at that time was Plan J, and they paid a portion of it.
Okay, well that's a mistake. Good for you. Yes.
Maybe I'm pretty sure, but it's.
normally civilians don't even submit claims, even to the supplement. There's a Part B crossover, and the information goes electronically from Medicare Part B to the supplement, and you just get your Medicare summary notice. And if the doctor's opted out, they can't submit claims. So that's a good for you, but that's a fluky thing. Yeah, and retiree medical is all over the lot. Rich retiree medical used to pay better, but most retiree plans caught on to that, and now they will process the claim as though the doctor was in Medicare, which disallows most of the charge. You know what? I think I really need to move on. I'm on Part A issues, so we're at the end, and then we can take questions. I want everybody to understand how Part A works, because it's not anything in terms of hospital coverage like non-Medicare coverage is. And it's rare that you exhaust Medicare, but a real concern is because our medical technology becomes more and more and more advanced, that it will become less rare. But to exhaust your Medicare means your private pay in a hospital. And trust me, you do not want to be private pay in a hospital if that is at all something that can be avoided. So let's talk about how Part A works. You have 150 days in your Part A hospital bucket in a benefit period, and you have unlimited benefit periods over the course of your life. But you can exhaust your Part A within a benefit period. And I'll just give you a couple of examples of situations we've dealt with that'll make that clear. But of those 150 days, the first 90 will always replenish as long as you then have 60 days where you're not using your Part A at all. The term is you were facility free for 60 days. But the last 60 days are lifetime reserve days, for once named pretty well. They are reserve days, they never replenish. So, to give you an example that people remember stories better, I think, we had someone who was not our client, or this wouldn't have happened to her. So she turned 65, was totally healthy, decided, I don't need Part D, I don't need a supplement, I'm fine. Had a massive aneurysm in New York City on a weekday day. And there was just an inexplicable delay in getting her via ambulance to the hospital. So she was terribly impaired. Her husband was not American. So trying to explain our healthcare system to him was another challenge. But as she approached like her 80th day in the hospital, he finally heard me when I said, you have to understand, because again, in New York, we got her a supplement immediately, but 6-month waiting period. All right, 6-month waiting period. So at day 90, she would have started using her lifetime reserve days. And if she stayed for 2 more months, she would have exhausted her Part A in that benefit period. Now, he decided to take her home with 24-hour care to replenish the 90 days. Believe it or not, but you just don't want to be in that situation. That's why the supplement is so important, to have the extra 365 days in there, or to know what your retiree medical might supply. We've had a number of people eat into that 365 days, never beyond like 180. But here's a more typical scenario, and this happened to a Westport couple. And again, my book is full of all these case studies and they're all real, they're not made up. This woman was very ill and elderly, multi-system failures. Her husband was a lifelong GE employee, so she had pretty good coverage. But even if they had known how to talk to the people at GE, if you get on the phone now at the people at the end of the 800 number, if you ask them, do I have catastrophic hospitalization? You generally don't get a very good answer because they think Medicare can never be exhausted. And that's not true. So this woman was more typical in that she was discharged home. Actually, she was going into the hospital, going to skilled nursing, going home, but getting readmitted and just never getting those 60 straight days that would entitle her to replenish her 90 days. Now, her Medicare was exhausted in June, I think, and she didn't pass away until October. And her estate got an $800,000 bill from our local hospital. So that was devastating. The hospital accepted $500,000, but that was devastating to that family. And quite ironically, again, she could have gotten a supplement in our state. Not everywhere, but she could have. And you know what? The Medicare summary notices, once we got them all, we're going to the home, but the husband was elderly and ill too. You know, the Medicare summary notices, I mean, we know the language, so maybe it's easier for us, but I think they do try to be pretty clear. But you know, these Medicare summary notices are going, you know, you may be billed $100,000, you may be billed $200,000, you may be billed $300,000, and there's the husband and 3 adult daughters in and out, but this wasn't registering with anyone. So I'm trying to scare you to get a supplement if you don't have one, so that you have this protection, because even to have a high deductible F is such a bargain in Connecticut through Anthem right now, and that would give you that extra 365 days. Let's talk about observation beds. This is a real hot topic right now. If you get admitted to the hospital, you want to make sure they consider you an inpatient. And the reason that's so important is hospitals have always been under pressure to scrutinize who Medicare is paying for while they're hospitalized. We didn't talk about my background, but I've been on both sides of this. So the first part of my career was as a hospital administrator, and this department that did the utilization and concurrent review reported up to me. So I know this well. Basically, hospitals want to have delegated review. That means Medicare has said, you've done a pretty good record, we're going to trust you to determine who should be in the hospital and when they should receive a notice that Medicare is no longer going to cover. But of course, Medicare audits and short stays have always been the ones focused on. And yet for Medicare to cover you in a skilled nursing facility after your hospitalization, you have to be an inpatient for 3 days and go to the nursing home with the same diagnosis. So if you are admitted under observation, which can happen if you've got something that doesn't really require a lot of treatment, you're on bed rest, then Medicare is still going to cover you, but under Part B. And so there's not going to be any skilled nursing facility coverage should you go there, because you haven't met your 3-day requirement. And this has become a very hot issue of late, lots of litigation, because part of the Affordable Care Act has required hospitals to pay penalties for certain readmissions within 30 days. And so this has probably exacerbated the incentives to admit people under observation. So you just need to have some family member who's going to be totally in the face of whoever you're dealing with in the finance office at the hospital to make sure you're considered an inpatient. Or if you're just on bed rest, maybe you shouldn't be there, but you should know that that is a very perplexing problem right now. Yes?
When you say observation, does that count as inpatient, or I'm
No,
not clear on your
no,
definition?
no,
Okay.
no. So Medicare will cover, but under Part B. And then the real kicker is if you need to go to a skilled nursing facility. Medicare's skilled nursing facility coverage is tied to a hospital admission. So you don't ever, unless you've just recently been discharged, just go from home to a skilled nursing facility and have Medicare cover you. Okay, last topic, and this is sort of an unusual one too, but there are people who don't qualify for premium-free Part A. And I just want people to know that if you're a U.S. citizen or a legal resident, you can buy Part A. This year I think it's something like $441. But every year we learn something new. I mean, last year we had referrals from labor attorneys. I never thought we'd get referrals from labor attorneys, but it was a number of clients who had had high-level positions that were separating from their companies. And what we learned was that the attorney representing them just saw their job as negotiating payment for COBRA coverage for 18 months, right? So as we discussed before, some of those people missed their special enrollment. So that was like shooting yourself in the foot. Similarly, this year we have a client who's 75 and never got on Medicare and misinterpreted, and she has very high-end advisors in Manhattan, but she misinterpreted a letter from Social Security that said she's not entitled to Social Security on her own work record. And so she thought, well, I don't get Social Security and I don't get Medicare. But she had a marriage that lasted 15 years. So she actually was eligible for premium-free Part A and to get on Part B and to get Social Security under his work record. But what a project it is now, 10 years out. And what's even worse, in New York has a very different individual insurance marketplace. So she's paying now about $2,100 a month for her individual coverage. So she's paid dearly for not understanding this. And it was a project to get, because she's divorced, so we don't normally help people apply for Social Security, but I went to her apartment, because she's not very mobile, to just be on the phone. And of course, she didn't have this ex-husband's Social Security number, so it was more of a process. But anyway, Social Security is tied to Part A. So once she got her Social Security, she had her Part A, right? But we can't get her Part B until next July 1, because she can only get it through her general enrollment period, and she's going to pay premium penalties for life. And we can get her Part D for January 1, and she'll have duplicate drug coverage, but that's what we have to do, because that's part, you know, we're in Part D's open enrollment now. So she's the poster child for how bad it can be if you mess this up. Another client I just feel so sorry for, because she was eligible under a first husband for premium-free Part A, and she married a younger man when she was 64. Big mistake. Big mistake. No, I'm serious. We had no idea that she, because this system is really, in many ways, designed to protect the at-home spouse, which she had been. So it would never have occurred to me that someone could lose their entitlement to premium-free Part A by remarrying, and because her second husband was not yet 62, she was not entitled to premium-free Part A. Now, she didn't become our client for many, many, many years, and so she ultimately paid in over $50,000 to the government. She never used her Part A, and we never even told her, well, you didn't need it because your husband had active group coverage, but you know, we did get our money back, but it was quite a project. We figured out, because some of these things aren't in Medicare and You, that she actually was entitled to premium-free Part A January 1 of 2003. And she had when the younger, there were two things. The marriage had to last a year, and the person whose work record that you're getting Part A from has to be 62. So a happy ending that she ultimately, I mean, this took 3 visits to Social Security offices, many letters, but then after about a year, when I'm thinking, I guess we have to go to the congressman or the senator now, she emails me, and she had gotten quite a hefty sum direct deposited into her account from Social Security, so she was pretty happy. But again, just there are a lot of just pitfalls that you might never even imagine, even when you live this stuff. So you've been wonderful. We have plenty of time. Let's take everybody's questions now. Yes?
You said that Part A is tied to Social Security, correct?
Well, let me clarify that. If you're getting Social Security, you're on Part A.
Okay, so the question is this.
But you can defer Social Security and get Part A.
What if you decide to continue working beyond age 65 and you have medical insurance through your company, and so you don't go to Medicare? That's all legal? You don't have to do anything?
Depends on how big the company is. Most companies that are small, under 20, the insurance contract requires that you be on Medicare A and B. And this is very, very commonly misunderstood. As long as it's a company of 2 people, not a sole proprietor, which is a group of 1, as long as it's a company of 2, you'll still get a special enrollment period from Medicare. But if your group contract says if you're Medicare eligible, you're supposed to be on Medicare A and B, you want to be on Medicare A and B. So you have to check that out. And you have, there's a great deal of misinformation out there about that. And then, you know, you have brokers saying, keep your individual coverage and you can avoid your income index B. But, you know, people who are selling non-Medicare insurance don't usually understand that that's not going to give you a special enrollment either, keeping your individual insurance. So you have to know if you're supposed to be on A and B, and that's more the insurance company and Medicare rules. Let me tell you, we had a gentleman who didn't understand this, and he had an Oxford plan that required him to be on A and B, and the broker had kept telling him, oh, you just call. Well, no, you don't just call. You get the forms, you know, the whole thing. But for some reason, the Social Security did not believe that he actually had a business. And he did. You know, I've been there. I've been in the Gray Bar building and seen the people. And after he went to Social Security for I don't know how many times, and they said, you're not entitled to a special enrollment. That's why we were retained. And he even had the letters of creditable coverage. I don't really enjoy going to Social Security offices, but, you know, occasionally you have to. And I went into Stanford, and they said, well, we can't talk to you. We can't talk to you about this New York man. I said, I know, but you can listen. Here are his forms, and here's everything, letter of creditable coverage. And it says group coverage certificate on it. And they left me there for about a half an hour while they conferred, and they came back with a policy document that basically said sole proprietors, again, a self-employed person, isn't entitled to a special enrollment period. And I said, well, all right. What on earth, what else could this gentleman need to satisfy you that his small business is really a small business? And they wanted a letter from the broker with every employee and information, you know, and I called the broker. He says, well, that's a HIPAA violation. I said, oh my gosh. Well, we've got to produce it, or this guy is never going to get his Part B. And he did. So it can be, that is a precarious area. The other one is, if you're on Part A and the active group has the kind of plan that is coupled with a health savings account, not a flexible spending account, not an FSA, a health savings account, you are not supposed to be able to contribute to that health savings account or have an employer contribute to that health savings account if you're on Part A. And those are just IRS rules. So for example, we have people in Norwalk where she's younger, she's the teacher, she's got that kind of plan, the husband is older, he's on the group plan too, and but she can only have her employer contribute to the health savings account the amount associated with an individual, not a couple. She can still use that money for out-of-pocket for him, but the employer and the employee cannot make those contributions since he's on A, on his behalf. Yes?
Is there any discussion of legislation that would prevent U.S. doctors from withdrawing from Medicare?
Not to my knowledge. Not to my knowledge. You know, the problem is Medicare rates are low. I mean, Medicare rates are low, and so we have this problem of it being made up in the non-Medicare side, and then now, you know, there's just so much cost shifting, and it's a real problem for our country. But, yes?
I have a two-part question. One is supplemental insurance. You said that the best three is Medicare, USAA, United Healthcare, I mean, Blue Cross Blue Shield, and AARP. What is the best way? Should you use a broker to research which would be the best value for you since the prices vary so much? And the second part of that question is, when you're researching Part D, I mean, are you better off splitting the two policies or getting one of the same, getting your supplemental and your Part D under the same one? There's no like insurance where you get a better deal for having them both together. Right?
Okay, let's clarify that. If you have a supplement, you should also have Part D, because that's how you have your drug coverage. But it's a Medicare Advantage plan that may or may not have the drug coverage in it. So if you have a Medicare Advantage plan that has Part D, no, you don't separately enroll in D, you're in that kind of plan. If you are on a Medicare Advantage plan that doesn't have drug coverage, then you also need Part D. But let's say you enroll in an AARP supplement and an AARP drug plan. You don't get a discount. The supplement, you might get a spousal discount or a pay a year in advance discount, but you don't get a discount for bundling those with the same person. And you have to remember, people, you can have your Part D premium taken out of your Social Security check, but you have to pay your supplement premium. And if you haven't taken Social Security yet, let's say you're deferring to 70 or whatever you're deferring to, you need to remember, if you're getting premiums associated with income indexing, you're going to have to pay your Part B premium, your income indexed B, and your income indexed D to Medicare. And you're going to have to pay your Part D premium to the plan. Okay?
What's the best way of researching which one of those is the best value?
Well, you know what? You know, the best way, I think, is to read my book, which is so cheap. Because brokers really don't want to deal with these things. There's not enough commission money in them. And the brokers who are selling aggressively tend to be the brokers dealing with the expensive products because that increases their commission.
Is the book available on Kindle?
It is.
Excellent.
It is. It is. But again, free advice, we usually recommend F or high deductible F.